So we'll start with the next session, the session 2. The theme is epidural anesthesia. The expert for this session would be Dr. Sandeep Kulkarni, who is a consultant in anesthesiology at KK Women's and Children's Hospital, Singapore. The first speaker would be Dr. Deep Arora. The topic is implications of epidural anatomy for regional anesthesiologist.
Good afternoon, everybody. My compliments to Dr. Sandeep Diwan and his team for achieving this mammoth task. And Dr. Sandeep Diwan happens to be cracking the whip, so it has to be T15 now, firing straight away. So topic that has been given to me is implications of epidural anatomy for a regional anesthesiologist. So we spend the next 12 or 13 minutes studying the anatomy. This is not of this lady. She is a celebrity who chose to undertake to take the epidural for a childbirth. So the epidural space is perhaps the most explored space of the human body. Ever since it was described by Corning in 1901, it is not actually an actual space. It is more like a potential space, just like the pleural space, where you can open and reopen it frequently without causing it any damage by injecting fluid into it. And the current method to study this space is cryomicrotome sections in fresh frozen cadavers. Now in the intrauterine life, it starts getting formed by 13th week, and by 39th week there are fat cells which begin to develop to occupy this space. Now we know that the first typical looking vertebra is the C3, first C1 and C2 being atypical, and the cervical, the vertebral column has its own curves. Because of the angulation of the spinous processes, we need to angulate our needle, especially when we are seeking the epidural space using the midline approach in the thoracic region. And this slide shows the effect of flexion of the spine as it opens the intralaminar space, making the access easier to us. Now vertebral column continues to grow and the spinal cord has stopped growing, so what happens is, as a consequence, the lower thoracic, lumbar and sacral nerves have to travel longer distances down so that they can exit their corresponding foramina. Coming to the epidural space proper, now we look at the spinal canal, which is occupied by the spinal cord, covered by its 3 meninges, and whatever space is left outside the dura is the epidural space. And it extends from foramen magnum up to sacrococcygeal membrane down below, and anteriorly we can see the relations, the vertebral body, the disc, laterally the pedicle, and posteriorly the lamina. Now when we are accessing the epidural space, especially in midline, the needle traverses through various ligaments. We'll just take a brief look at each one of them. Now while training during my MD days, this is how we used to train to get a feel of the ligaments of the epidural space, and now of course you have these trainers or the phantoms which are in use. Talking about the supraspinous ligament, which extends from C7 to sacrum. Above C7 to the external occipital protuberance, it is known as the ligamentum nuchae. It's a thick fibrous ligament which prevents us from palpating any of the cervical spinous processes, and the first one that we can palpate is C7. So this ligament contributes to the stability of the spine. The interspinous ligament is the next one, which connects the shafts of the spine. It's a thin ligament but has a very characteristic gritty feel, so much so that especially in young adults, when you're targeting the epidural space in the midline, if you don't get this feel, so you better reconsider whether you are actually in midline or away from it. The next ligament that comes in our way is ligamentum flavum. It is an elastic ligament which contributes to the mobility, allows the mobility of the spinal cord within the vertebral column. It is made up of elastin and collagen fibers. It has 2 halves which meet at acute angle in the midline, and it has 2 layers, a superficial layer which has fibers going upwards and medially, and a deep layer which is fibers running from craniocaudally. So the classical teaching that used to be that the bevel of the needle has to be parallel to the fibers, so tell me which way. So it's just a myth because the fibers are running every which way. And this ligament gets thicker as we go from up from above downwards. So therefore, we get a better feel of this ligament in the lumbar region where it is as thick as 5 millimeters. And these two halves, which I talked about, may not unite in the midline, especially in the cervical, lower thoracic, and upper lumbar region. So a loss of resistance may not be reliable, all that reliable in the midline, especially in when we do it more often in the lumbar region from L to L5, as high incidence as 10% where it doesn't unite. And L5 S1 is one space where it has been always shown to unite. Dimension of the space is anteriorly it is very shallow, posteriorly it is deepest, and laterally it extends as far as the dorsal root ganglion, as in the form of a dural cuff along the nerve roots. And you will appreciate that it is obliterated in spaces all around. So as a result, this space is composed of a series of discontinuous compartments which tend to open up as we inject local anesthetic solution, just like two sheets of polythene stuck together, and as we inject fluid into it, they open, and the larger the volume injected, the more homogeneous is the spread. Coming to the width of the epidural space, studies have shown that a shallow epidural space is more associated with accidental dural puncture, while a deep one is associated with an uneven block. So we know what to blame when we don't get a good block. When we're doing a high thoracic epidural, the injection should be at a slightly cranial level, not in the middle of the dermatomal spread that we want to achieve, because the spread is more caudal preferentially. In lower thoracic, it has to be caudal because here the spread is more cranial. These are the contents of the epidural space: fat, the veins and arteries, lymphatics, and spiral nerve roots. The fat acts as a shock absorber, also lubricates the dural sac movement within the spinal canal, and the amount present is independent of the fat present elsewhere in the human body, and it's a relatively vascular fat. It is distributed mostly in the dorsal space in the form of a vascular pedicle, and this pedicle may come in your way when you're trying to look for a loss of resistance, and also when you're trying to thread in a catheter. And this fat is also distributed more towards the intervertebral foramina, where it lies right next to the nerve roots, and where it acts as a depot, a reservoir for whatever local anesthetic we have injected in the space. Like here, right next to the nerve root. So it's a ready supplier of local anesthetic or whatever it has stored. Now with age, it gets denser and lesser in quantity. In scoliosis, there is an uneven increase in this fat. In lipomatosis of the epidural space, there is an unduly increased amount of fat, which can cause failure of your block or can result in patchy block. When there is lumbar canal stenosis, there is a reduced amount of fat, and this seems to enhance the effect of local anesthetic that you inject. There is a controversy whether this midline dorsal fat pad exists, which tends to cause an uneven spread of local anesthetic, and this study presented in ASA 2011 seems to confirm that there is an asymmetrical spread of contrast that they studied in this study, which resulted in which kind of goes to prove that there is an existence of this particular medial fold of fat in the epidural space, in the dorsal epidural space. Now the arterial supply, which comes in the form of segmental arteries, the arteries enter the spinal cord, the epidural space, via the intervertebral foramina, and the importance of this is that when we're doing a transforamen epidural steroid injection for chronic pain procedures, in chronic pain, if we happen to inject it in this particular artery, it can result in serious damage to the spinal cord. And veins, we know there is a valvular system called the Batson venous plexus, which communicates freely with the azygos system in the abdomen, and so abdominal pressures are easily communicated. So in pregnant women, we have a higher chances of causing a vascular puncture, and as also in patient who is lying prone during spine surgery, if there is abdominal pressure which is transmitted to the veins. Now the epidural space communicates laterally in thorax with the paravertebral space, and some people say that this is responsible for the negative pressure that we find in this space, while others say that it is the tenting of ligamentum flavum by the needle that we have introduced trying to reach this space which causes this negative pressure. And this loss of resistance, and there are many methods commercially available now in the market trying to help us to locate this space. When we use air as a medium for loss of resistance, it has been shown to be associated with pneumoencephalus and higher incidence of dural puncture, and we use saline. It is considered safer, but then it might result in, depending on how much we end up injecting, in diluting the effect of the local anesthetic. The skin to epidural space is roughly about 5 centimeter, the distance, and this depth is related to the body weight. It increases as we increase the body weight. Approach is intralaminar. It can be midline or paramedian. Interlaminar midline approach is simple. That is what we conventionally are taught, but it is, has been associated with more incidence of catheter migration, while paramedian approach is a more reliable way to pass your catheter cranially. This is the Taylor approach, already been talked about. In sitting position, we find somehow most of us feel that it is easier to get to the epidural space, while in lateral position, though it has been conventionally taught, it is technically a little more challenging, and prone position is preferred by pain physicians. Coming to the notorious landmarks, it has been highlighted earlier that how inaccurate they can be in trying to locate a particular space. Coming to the caudal epidural, we have to know that sacral hiatus is palpable in only 21% of adult population, and it is absent in as many as 6%. And caudal epidural is associated with about 10% of patients with intravascular injection. Spinal cord ends at L1 in adults, can go down to L3. In neonates it go down to L3, L4 anyway. Dural sac ends at S2 in adults and S4 in neonates. So pediatric caudal, what is so special about it? The depth to the space is roughly, we can have an estimate that it is 1 millimeter per kg, and the dose, as I said earlier, that there is hardly any fat in that epidural space in this age group, so the dose is practically half compared to older children. And on the other extreme, we have that spine, and in both these cases, I'm not talking about ultrasound because many people will talk about it. So just a few slides on spinal canal pathology, how a distorted anatomy can help us. Dr. Kumar also mentioned this particular eventuality when patient comes with radiculopathy or spinal canal stenosis or diabetic neuropathy, and we end up compounding the injury by causing more damage. So we have to be careful. This is a patient with a prolapsed vertebral disc causing impingement of the nerve, and it has been shown that instead of giving a conventional epidural injection, a transforamen epidural steroid injection is more helpful because it entails a targeted delivery of local anesthetic and steroid to the point of injury. And just to re-emphasize the fact that high concentrations and volumes of local anesthetic should be avoided at all times, especially in patients with nerve compression, large disc herniation, or spinal stenosis. Ankylosing spondylitis has already been talked about. It is associated with a higher risk of epidural hematoma. Scoliosis in mild to moderate, we can still attempt to do an epidural if we utilize a paramedian approach from the convex side of the curve. Coming to complications of epidural, these are all the complications. Most of them result because we don't realize which level we are attempting to target, and it has been shown that in those epidurals which fail, at least in half of them the epidural catheter or epidural needle was not correctly placed, in the other half it was, so other factors also come in. And then there is this catheter migration. The catheter can go out from the epidural space into the intervertebral, out of the from the foramen, and so you will not have a good block. and sometimes it lands up in the subdural space where you have a patchy and high block, which can even cause unconsciousness and pupillary dilatation, because this subdural space is in communication with the intracranial space. Finally, 15th minute I've finished. Thank you very much.